Hello and welcome to the Demonstrating Implementation Excellence stream of the SNOMED CT Expo 2021. My name is Elaine Wooler and I'm a Senior Terminologist at SNOMED International, and I'm very pleased to be introducing today's session. Please use the live Q&A in your AirTouch device to type any questions you have for the presenters. All questions will be answered at the end of the presentation. I'm now pleased to introduce Sara Russo and Fernanda Bigolin from Portugal's Ministry of Health Shared Services, who will be presenting SNOMED CT at the point of care, the oncology ecosystem. Sara and Fernanda, please proceed.
Thank you. Hello, everyone. Good afternoon from Portugal. Thank you for being here. In this presentation, I will provide an overview of our organizational methodology to standardize the oncology registries. So just a glimpse about our national context. We are approximately 10 million citizens. We have 54 public hospitals and 359 primary care units, although they could have more than one building. These public institutions are divided in our 5 healthcare regional administrations. And one thing that is unique in Portugal is that 90% of our healthcare information systems is being run by SPMS. Besides the number of institutions presented in the previous slides, there are also central organizations that are part of our Ministry of Health, and the ones that are highlighted in this presentation here in this slide are the most relevant ones for the purpose of this presentation. A quick overview about SPMS. So SPMS is responsible for purchasing and the logistics. We act as the central procurement agency for the healthcare ministry to buy on behalf of our entities. We procure medicine and IT products. The information and communication systems and technologies is our primary care, one of our primary care activities. The software that the hospitals or other types of care provision entities use for most of their activity, like admitting a patient, documentation or discharge, are produced by SPMS. And we also host a national center for telehealth and a health service contact center. Considering the central organizations that are part of our Ministry of Health, we have drafted a collaboration protocol with the key public entities to create a clinical terminology center. And with this collaboration, we have a strong driver to promote Semantic by gathering the different approaches of the healthcare provision. Because when we are producing a national catalog, we can combine these 3 areas of expertise, the clinical one that is provided from the DGS, they provide clinical guidance, the financial perspective from the ACSS, which is our financial ruler, and then we have the SPMS for the IT governance and the technical implementation. But having this organizational structure isn't enough, so we need to have a process to manage each catalog development. During this life cycle, there are different players that intervene in the process. We have our technical team that is responsible for the translation and to understand the terminology and the classification structure. However, and since we want to provide value to our ecosystem and ensure that each business need is responded, we need to work with groups of healthcare specialists that provide advice and make proposals about specific subjects. Recently, we have started to work with some, as we called, programs of the Directorate of General of Health, the DGS, that are groups of experts in a specific field. We have, for example, the National Program of Vaccination, the National Program for Promotion of Healthy Eating, and then we have our key managers that are the members of the representatives of the DGS, SPMS, and ACSS that make the decisions collectively and approve the catalogs. Passing through this brief overview of where we are and which group of entities are responsible for managing the semantic structures that we built, let's move to the organizational aspect and the strategy that we are adopting to carry out the initiative of harmonizing the oncology ecosystem. Our oncology ecosystem that we are trying to build is just a small piece considering the rest of the ecosystem. We already had a national oncology register that was born from the centralization of the regional oncology registries, and it has all data related to all patients with cancer diseases. And this national oncology register is being used to explore data, mainly for secondary use of data. And with this initiative we are presenting here, we want to be focused on the clinical pathway, how to manage the clinical perspective of the oncology journey. So to pursue with this initiative, we defined some goals. We wanted to promote standardization by the adoption of semantic catalogs based on international terminologies. We've also wanted to promote interoperability between the different players, such as the primary care units, the hospitals, the oncology centers, or other types of healthcare units that deal directly with a patient with a cancer disease. And we also wanted to be aligned with the European initiatives. So the next step was to identify responsibilities and to invite a team of experts in the oncology field. The coordinator team is the owner of this initiative, this oncology initiative, and is in charge of overseeing the process and the details of how to reach the proposed goals. And this coordinator team has on its dependency a technical team that will develop and implement the system, the oncology system. And this coordinator team is communicating very closely with SPMS Enterprise Architecture team. Together contributes from related to business and information architecture to understand how the oncology ecosystem is organized and help with the definition of controlled vocabulary. The consultant team has representatives from different regions of Portugal to guarantee that the regional approaches were captured in all our models. So we came up with public hospitals, with public cancer institutes, private healthcare units, and the National Program for the Oncology Disease. In this phase, the consultant team we are working with is composed by 11 healthcare entities from public to private sector and 13 physicians. Not all of them are oncologists. We have oncologists, GPs, anatomical pathologists, and general surgeons. And as a first step, we have to draw different business processes to capture the activities that translate an action in the information system, and how the information flows through the different actors that are involved in the oncology process. Since the patient screening and the eventual diagnostic hypothesis, the diagnosis itself, the treatment, the continuous follow-up until the end of the patient journey. Our enterprise architecture team, specifically the business and the information architecture members, have recently started to define some domains, which are business information models that aggregate different elements to describe a healthcare concept. And for each element, we have identified the value sets that will support this element. In the specific context of this project, we tried to link each business process activity with the elements that are defined in the business information models. This slide points out some terminologies and classifications that we are thinking on use. We want to take advantage of the rich set of inter and hierarchical relationships between SNOMED CT concepts to standardize the more generic field of oncology that are common to the other medical specialties, and for specific areas of oncology, such as the staging. We will find other terminologies to support the oncology care as a whole. And this approach allows the development of a complete and structured model with different layers of specialization. Beyond the semantic viewpoint of this project that is captured by the business and information architecture, we also need to understand how semantic relates with the technical interoperability. So now I hand over to my colleague, Fernanda Bigolin, that will describe the binding between the business information and the FHIR. Thank you.
Thank you, Sara. Continuing the presentation, SPMS has adopted the FHIR standard to achieve technical interoperability and together the use of terminologies as SNOMED CT. By combining these two standards, system using SNOMED CT and FHIR together are able to communicate clear meaning in a standard way that can be understood otherwise. We are presenting this slide a brief background on FHIR. The standard was created by HL7 organization. The solutions are built from a set of modular components called resources. One of its goals is the facilitated interoperability between health systems. To facilitate the delivery of health information to healthcare providers and individuals across a range of devices, as computer, tablets, and mobile phones. About terminology model, the clinical concept described as business information can be related to the FHIR resources and are supported by code system as SNOMED CT. Our next steps are to work on binding from Semantic to FHIR. In this slide, we presenting the one resources on fire. For example, condition. We work in SPMS based on fire resources. For example, condition. This example is to show the link between fire and SNOMED CT. This involves semantic and interoperability. In this example, SNOMED CT can be used to represent one of the elements of these resources as body site, when you see in these parts. So for this year, we presented an overview regarding the organization structure, but next year we hope to dive into the oncology information characterization. Thank you for your attention.
Thank you, Sara Fernanda, for your presentation. That was a really excellent insight into the use of SNOMED CT in the oncology patient journey, and you're clearly taking a very integrated approach, which is excellent. Now to the questions. Can I just ask that you give us a moment while we switch over from our pre-recorded content so that presenters can answer the questions you've been submitting live. Just a note, the session will be available on the event platform for the next 3 months, so feel free to revisit and perhaps learn more. Thank you. Hello everyone, yes, we're now live. And can I just remind people that to use the live Q&A button in the AirTouch device to type your questions to the presenters. And we've got one that's already come in from Vadim. Can I just ask, what are some of the things you would have done differently if you were to start today?
I think we tried to plan a lot the work that we did. So at least from my perspective, I wouldn't change the approach we had, because I think we followed the main steps that are provided by the architecture. At least the process that we should do. So I think, at least from my perspective, I wouldn't change the organization that we prepared.
Okay, thank you. I mean, just to follow on from that, really, can you see this oncology ecosystem, the approach that you've taken with this, can you see this being used in other clinical areas?
Well, this project came up as a need, and we tried to respond to that need. So I'm sure we are going to expand to other clinical areas, but at least at the moment, we do not know to which specific area we are going to be focused.
Okay, and I'm sure when the word gets out and people see the work that you've done, then there'll be probably other people with their own needs that are going to start approaching you, I would imagine. So it was interesting as well that you used, as people do with these sort of catalogue development processes, you use direct clinical input. How easy was it getting that clinical input, and in terms of how did you recruit the clinicians?
In Portugal, as I said, we are divided in regions, and for each region, we had different oncology registries. So first we tried to merge these regional systems to one, the national oncology system. But this was mainly focused on it was developed for data exploring. So we have physicians that are responsible for this national registry. So we first contact the coordinator of this national registry, and we also have a program, a specific program from our Directorate General of Health. There is a program for national oncology diseases. So we contact this program, and then we started to contact also some specific entities that we have in Portugal that are focused on the oncology disease. We have the Portuguese Oncology Institutes. So we have also physicians from this type of institutions. So this is the way we try to contact the physicians that are working with us.
Excellent, thank you. And in terms of the ongoing maintenance of the catalogue, I mean, are you at a stage where you know what that's going to look like, or is it too early? I know you're in the very, very early stages.
Well, I think it's a bit early because we are still trying to finish all the processes because there are a lot, and the oncology ecosystem is very complex. But we are just trying to see which type of information we should link to each activity. But at the moment, we do not think on maintaining the document, the catalogs, because they are not all developed. Some of them are, but I'm sure that all the physicians that are involved in the projects will collaborate to maintain the catalogs and to make sure that their needs are all expressed in the catalog.
Excellent, thank you. We don't seem to have any further questions. I don't know if there's anything else you want to say before we go, or we can finish early. That's absolutely fine. Anything else you'd like to say? Okay. Right. So if anybody does have any additional questions, I'd encourage you to connect via the meeting hub after the event. So finishing early, you've got a few minutes to go and get a cup of tea before you're on to your next session. So thanks for joining us, and enjoy the rest of the expo. Thank you.
Thank you.